Hello, I'm Kevin Wei, and I'm here today to discuss the impact of contrast for left ventricular opacification. I would like to make a disclosure for this presentation and let you know that I will be discussing myocardial perfusion imaging briefly, which is a non-approved use of contrast. The learning objectives for this presentation are to review important ultrasound fundamentals. We will discuss imaging modalities for left ventricular opacification and machine settings, determine the pitfalls and optimization of contrast for left ventricular opacification, and most of the presentation will, of course, deal with a review of the clinical utility of contrast for left ventricular opacification. I wanted to start by reviewing some fundamental ultrasound principles which will be pertinent to the entire presentation. As all of you know, the alternating high and low pressure cycles of ultrasound can be represented by a sine wave. And as these cycles pass through the medium, they cause alternate compression or rarefaction of the medium. The strength or amplitude of the ultrasound wave is represented by the peak negative pressure of the wave. If the ultrasound crystal is excited to a greater degree, an ultrasound wave with a larger amplitude and a larger peak negative pressure and greater acoustic energy will be produced. Thus, the mechanical index of ultrasound is directly proportional to the peak negative pressure. As shown in this formula, however, mechanical index depends not only on the peak negative pressure, but also on the frequency itself. This is because for two waves with the same amplitude and peak negative pressure, the higher frequency wave has a smaller total area and therefore overall less energy compared to a lower frequency wave of the same amplitude. When harmonic imaging was first developed for contrast-specific imaging, it was not anticipated that myocardial tissue would produce such excellent harmonic signals. The way that tissue produces harmonics is through nonlinear propagation of ultrasound through the tissue. As the sound wave penetrates from the near to the far field, the peaks of sound wave here propagate more easily than the troughs. So as the sound wave passes through tissue, the peaks become compressed and the troughs spread apart, leading to a distortion of the sound wave. A fast Fourier transform of this complex wave reveals the presence of both fundamental frequencies in yellow as well as harmonic frequencies in pink. To actually perform harmonic imaging, the ultrasound system uses a low-pass filter to display only the harmonic signals. Ultrasound systems still give you the flexibility to switch between fundamental and harmonic imaging. As an example, on this GE system, harmonic imaging is called octave and is activated simply by pushing a button. This slide shows a cine loop using early harmonic imaging on an old Philips Sonus system. It demonstrates how the far field, such as the basal myocardial tissue, has more harmonic signals compared to the near field, but there is still clear delineation of the apical wall motion abnormality, and I believe everyone can see the laminated mural thrombus at the apex. Unfortunately, in many patients, even with harmonic imaging, visualization of the heart is far from optimal. This is where contrast agents designed to enhance the arterial circulation can be used to produce high-quality diagnostic images. There are currently 3 commercially available contrast agents in the U.S. Definity and Optithon contain a high molecular weight gas called perfluoropropane, which is encapsulated within a thin shell, while Lumason has sulfur hexafluoride gas core. These high molecular weight gases have low diffusibility and solubility in the circulation, allowing the microbubbles to persist after venous injection and passage through the pulmonary circulation to enhance arterial structures. Microbubbles, of course, also can produce harmonic signals when they interact with sound waves of the correct frequency, called the resonant frequency, at the appropriate acoustic power, such as a mechanical index of about 0.1. These sound waves can produce nonlinear oscillation of the microbubbles, as shown in the graphic in the top right corner of the slide. The expansion of the microbubble lasts longer than the compression phase, so again we have a nonlinear sound wave. These sound signals will contain both fundamental as well as harmonic signals. However, if the mechanical index of ultrasound is too high, for example above 0.6, it will destroy microbubbles. This cine loop from Dr. Lindner shows a microbubble exposed to a single pulse of ultrasound as a typical mechanical index which is used for 2D imaging clinically. The microbubble ruptures and rapidly disappears. Therefore, in order to preserve microbubbles during imaging for left ventricular opacification, low mechanical index must be used. The other advantage of using low mechanical index ultrasound is that there is much less tissue harmonics. So microbubble signals are much greater than the tissue noise. That is, the microbubble signal to tissue noise ratio is enhanced. The imaging modalities that are currently used for contrast-enhanced studies are no longer simple low mechanical index harmonic imaging. To further optimize microbubble signal to tissue noise ratio, a number of so-called multi-pulse techniques are now being used. The first example of these techniques is pulse inversion imaging. 2 pulses of ultrasound are sent out along each line, and the second pulse, which is shown in pink, is a mirror image of the first pulse in blue. When the signals returning from tissue are subtracted from each other, no tissue signal remains, so tissue noise is completely eliminated. On the other hand, the microbubbles do not produce linear return signals. They are nonlinear, and these nonlinear signals cannot cancel each other out. So harmonic signals from the microbubbles remain, leaving good contrast enhancement. Pulse inversion imaging can typically be found on GE systems, for example. Like all systems these days, the vendors have made it really easy to activate contrast imaging modes. For example, you just have to choose the probe in this case, activate the preset, and pretty much the system has good defaults that allow good quality contrast-enhanced images in the majority of patients. Another multi-pulse technique is called power modulation. Now, along each line of ultrasound, 3 pulses of different acoustic energy are transmitted. You can see here that pulse B is twice the acoustic power of pulse A, but all of these are low power pulses. The pulse A is added together and they are subtracted from pulse B, and again, the linear signals returning from tissue are canceled, whereas the nonlinear harmonic signals from microbubbles remain. Power modulation is a modality which is typically found on Philips systems. Again, it is turned on by just pushing a couple of buttons to activate the mode. As you can see here, the system defaults typically work really well for the majority of patients. Finally, contrast pulse sequencing, or CPS, combines both alternating phase as well as alternating power. Same principle is applied to eliminate tissue noise by subtraction of the linear signals returning from tissue, while nonlinear microbubble signals are not canceled. CPS is typically found on Accuson systems. Again, it is easy to turn on with the single push of the cadence button. And this is an example of contrast for left ventricular opacification using CPS. Now that we have covered some basic ultrasound physics that pertain to contrast ultrasound imaging and reviewed the different imaging modalities that are currently used, I would like to discuss some of the pitfalls of contrast ultrasound and review steps to optimize the images. The American Society of Echocardiography has some good resources on the contrast zone that you may find useful, as well as videos that show you how to prepare and administer microbubbles to patients. This image shows you some of the features of an ideal contrast-enhanced study for left ventricular opacification. The contrast in the left ventricular cavity should be homogeneous from the apex to the base. The mitral annular plane should be easily visible and should not be obscured by the contrast in the cavity. The tissue should be relatively dark and silhouetted against the cavity, but the specular epicardial border must still be visible so that wall thickening can be evaluated. Now, this cine loop is clearly suboptimal because the concentration of microbubbles in the cavity is too high and there is attenuation over the basal structures. This is often the result of either too large a bolus or a flush which was administered too rapidly. The quickest way to rapidly salvage this type of image is to turn up the mechanical index briefly to destroy the bubbles in the cavity, or just give the microbubbles a bit of time to dissipate. We prefer to use an infusion of diluted contrast to avoid attenuation, and the ASE online resources shows you how to prepare an infusion like this. This image is clearly also suboptimal because the contrast is swirling in the cavity and not delineating the endocardial border. In this case, as you can see from the MI in the top right corner, the mechanical index is too high. So the mechanical index needs to be turned down in order to prevent such dramatic microbubble destruction. In this image, the mechanical index, as you can see in the top corner, is appropriately low, but there is still inadequate contrast in the left ventricular cavity because the microbubble concentration is too low. Either another slow bolus is required or the infusion rate needs to be increased. If you are out of bubbles in the syringe, you could try simply lifting the patient's IV arm and massage the vein a little bit to encourage the entry of some bubbles that are left residual in the patient's vein. Now in this image, the mechanical index, the amount of contrast, all of that looks fine, but the tissue is extremely bright. The gains are too high in this case. For the rest of this presentation, we will move to discussing the clinical utility of contrast imaging. As all of you know, the assessment of left ventricular systolic function is the most common indication for ordering an echocardiogram. Contrast for left ventricular opacification has really enhanced the accuracy of quantifying left ventricular volumes and ejection fraction. This study from Yu et al. Compared left ventricular ejection from tissue harmonic imaging versus radionuclide angiogram on the left. You can see that there is up to 20% difference in left ventricular ejection fraction between the two techniques, with a lot of variability between the two techniques. On the other hand, when left ventricular ejection fraction is quantified from contrast-enhanced images and compared to nuclear data, there is much better concordance between the two techniques. This is why contrast should really be considered for quantifying left ventricular volumes and ejection fraction when highly reproducible data is required. For example, to determine left ventricular ejection fraction prior to device implantation, for patients with regurgitant valve lesions where the ejection fraction will alter patient management, or in chemotherapy patients getting serial echocardiograms for evaluation of chemocardiotoxicity. In situations like this, contrast should be considered even if the 2D studies are good quality. Contrast for left ventricular opacification can be used to salvage technically difficult studies and influence patient management. In this study from Baylor, Kurt et al. Recruited more than 600 patients with technically difficult studies. As you can see in this panel on the left, nearly 87% of the patients had technically difficult studies at the beginning of the study, and 12% were actually considered uninterpretable. After contrast administration, over 90% of the studies were considered technically adequate for evaluation. This graph shows the number of segments with abnormal wall thickening that were visualized before contrast administration in blue and after contrast administration in red. You can see that overall, the number of segments with abnormal wall motion seen after contrast given was nearly double the number that was seen before. This is particularly important in patients who were in medical or surgical intensive care units. The investigators then did something very interesting. They provided the referring physicians with the echocardiographic findings before contrast was given and asked them what additional procedures they would order or how they would change management. They then gave the referring physicians the echo findings from the contrast-enhanced study and again asked how the additional information would change the management. What you can see from this slide is that overall, 25% of additional procedures, like transesophageal echocardiograms, were avoided when contrast-enhanced data was provided to the referring physician. The impact of contrast was greatest in surgical ICU patients, where nearly 40% of additional procedures were avoided. 7% of patients had medication changes made to their management, and nearly 19% of patients had both medication and procedure changes made based on the information provided by the contrast-enhanced images. This graph shows the impact of contrast use on avoiding additional procedures, mainly transesophageal echocardiograms and nuclear studies could be avoided once information from contrast-enhanced images were provided to the referring physician. Furthermore, Kurt et al. Showed that contrast use is extremely cost-effective by reducing these additional procedures and decreasing downstream resource use. Contrast is actually incredibly cost-effective in these patients. Next, stress echocardiography is a situation where excellent delineation of all endocardial borders is critical for having accurate studies. Contrast use has been shown to improve confidence, reduce intra and inter-observer variability during stress echo. Again, when you are doing contrast-enhanced stress echocardiographic studies, it is very important to optimize the imaging settings so that both the endocardial and epicardial borders are clearly seen so that wall thickening can be assessed. And as you can see from the peak stress image, there is a wall thickening abnormality affecting the apex as well as the anterolateral segments of this patient at peak. Contrast-enhanced studies can also be extremely useful for evaluating patients with acute chest pain in the emergency department setting in particular. It can be used to identify or exclude patients presenting with acute coronary syndromes. This is a case of a 52-year-old male with no prior cardiac history, but he has a history of diabetes. He developed 1 hour of chest discomfort that radiated to his left arm after he ate a meal that was associated with shortness of breath. He presented to the emergency department, but his discomfort had already abated. He had a normal physical exam, normal electrocardiogram, normal chest X-ray, and his initial troponin was normal. Because of his risk factors, certainly ischemia as a cause of chest pain needs to be considered, but this could easily as well just be gastroesophageal reflux disease. The patient had an echocardiogram done shortly after he arrived in the emergency department, and you can see that he had a significant wall thickening abnormality affecting the left anterior descending territory. The mid-to-distal, anteroseptal, and apical segments are nearly akinetic. Because of this, there was a strong suspicion that the patient's chest pain was indeed due to an acute coronary syndrome. We went further ahead and evaluated myocardial perfusion with the contrast that was already in the cavity, and you can see that in the subendocardial region of the apex, there is a perfusion abnormality which identifies that there is still slow or low flow into those segments. The patient was therefore referred for coronary angiography. This revealed that the patient indeed had a very critical stenosis in the mid-left anterior descending coronary artery with slow flow distally. He had successful angioplasty of the lesion and was discharged home the next day. This slide shows that abnormal regional function is a very powerful predictor of adverse outcomes in patients presenting with acute chest pain to the emergency department. They had more than a 5-fold higher incidence of unstable angina, acute myocardial infarction, revascularization, or death within 24 hours after presentation. If patients had both abnormal regional function and abnormal myocardial perfusion, the risk of an adverse event was nearly 14-fold higher. As mentioned in the latest consensus document regarding contrast use from the American Society of Echo, contrast is particularly important for identifying apical abnormalities in patients. This is because there is always more noise in the near field as well as less tissue harmonics in that area. I will show you some examples of apical abnormalities that were picked up with contrast use. This, of course, is an example of a patient with a obvious apical wall motion abnormality and a pedunculated thrombus at the apex. This is a case of a 42-year-old male with diabetes, dilated cardiomyopathy that was diagnosed in Boise, and he was transferred to our hospital for decompensated heart failure and to get a cardiac transplant evaluation. He was on Lovenox, which was transitioned to Coumadin for an apical thrombus that was identified on his transthoracic echocardiogram at the outside hospital. This is the echo that was performed when the patient arrived at our institution. You can clearly see that there is a very severe global LV dysfunction, and at the apex, there does appear to be this increased echoes, which is concerning for potentially thrombus. However, when we administered contrast to this patient, you can clearly see that instead of an apical thrombus, the cause of his cardiomyopathy was isolated left ventricular non-compaction. So this not only allowed us to determine the cause of this patient's cardiomyopathy, but also identified that he did not have a thrombus at the apex. So this is another case of a patient who had chest pain that was referred for an echocardiogram. The non-enhanced images appears to show quite significant septal hypertrophy, but the anterolateral segments were not well seen. After contrast was administered, you can clearly see that the patient actually has apical hypertrophic cardiomyopathy. This is a very interesting case of a 70-year-old male who had a cutaneous T-cell lymphoma. He started to develop symptoms of worsening dyspnea as well as renal insufficiency. An electrocardiogram showed possible QT prolongation and new ST segment depression, and so he was referred for an echocardiogram. This is his 4-chamber view without contrast, and again, the non-contrast images look like he actually has apical hypertrophic cardiomyopathy. However, when contrast was administered, you can see that there is good contrast enhancement of the cavity, and when microbubbles started to enhance the tissue, we could see that there is a black space in between the myocardium and the cavity, which is a layered thrombus. So this image now shows us that the patient actually had eosinophilic endocarditis or Loeffler's syndrome, that of apical hypertrophic cardiomyopathy. Finally, this is a patient with a prior myocardial infarction referred for an echocardiogram. So on this apical 2-chamber view, you can again see a large true aneurysm affecting the basal inferior segments of the myocardium. However, it was not until after we had administered contrast for left ventricular opacification that we realized that within the aneurysm there was actually a filling defect, which you can see. So this identifies the presence of a thrombus within the aneurysm that had not been noticed before. Contrast can also be used to evaluate extracardiac anatomy. This is the abdominal aorta, and when color was placed in this area, it looked like there was not complete Doppler flow within the entire aorta. After contrast was administered, you can actually see that there is very, very bright contrast signal in the lower part of the aorta, which is the true lumen, and a darker area with no contrast, which is the false lumen. So this is a patient with a chronic type B aortic dissection. Finally, Doppler signals within the arterial circulation can be enhanced with tiny amounts of contrast. This is from the Journal of American Society of Echocardiography, which shows how an aortic stenosis jet was enhanced with contrast. Other signals that can be enhanced with contrast would include pulmonary venous inflow. So this is just a bonus that you can get at the very end of a contrast-enhanced study. You can wait for the contrast to dissipate to nearly zero and then turn on spectral Doppler to get these enhanced Doppler images. So in summary, we have discussed today the imaging modalities that are commonly used nowadays for left ventricular opacification. These include either low mechanical index harmonic imaging or some of the multi-pulse techniques which I discussed. These were actually developed for perfusion imaging, but we apply them commonly nowadays for left ventricular opacification. We reviewed important machine settings. For the most part, you can use system defaults, but please pay attention to the mechanical index. Microbubbles can be administered either as a slow flush or a continuous infusion, and you can go to the American Society of Echo website for further details. We reviewed different pitfalls and how to optimize images. Very little image adjustment is usually required, but If the tissue is too bright, you may need to adjust overall gain or TGCs. Sometimes the focus has to be adjusted to achieve homogeneous opacification within the left ventricular cavity, and you always want there to be clear delineation of the mitral annular plane and also to see both the endocardial as well as the epicardial border so that wall thickening can be assessed. If the images are good quality, then contrast echo has many benefits. It has been shown to increase diagnostic confidence, decrease inter and intra-observer variability, decrease the need for additional testing, which can improve cost effectiveness in patient management. It also helps to decrease missed diagnoses and prevent misdiagnoses. And all of these benefits will lead to improvement in patient management and decision making. I would like to thank you very much for your attention today.